Dear colleagues, friends, a warm welcome to all of you. Thank you for joining us in tonight's webinar, where we're going to be discussing obesity pharmacotherapy and focus on the oral GLP-1 and GIP incretins. You'll be happy to know that the webinar has received CME credits, and these will be available to you in due course after the webinar. This webinar has been made possible through an unrestricted grant and support by Eli Lilly, and would like to take this opportunity to really thank them for that support. My name is Dr. Khadija Hafid, and I'm a consultant physician and diabetologist based at Rashid Hospital in Dubai, and I'm super delighted to be sharing this virtual platform with an excellent panel of speakers who also happen to be friends. So just a few housekeeping notes. The webinar is live streamed on the Endocrine Diabetes, the Emirates Diabetes and Endocrine Society YouTube channel, and will be available on demand later on for future viewing. As I mentioned, you will be receiving your CME credits later on. We would love to have your participation, and so we encourage you to put in your comments, questions by using the Q&A button, and we'll try and address those at the end. We do have a rich agenda, and I'm delighted to have, as I said, an excellent panel of speakers. We're going to start off with incretin biology and the breakthrough in oral delivery, which will be delivered by Professor Barbara McGowan. She is a celebrated clinician scientist who is also a professor of diabetes and endocrinology at King's College London, and a consultant endocrinologist at Guy's and St Thomas's, also in London. She is the clinical lead for obesity service, specializing in the management of complex obesity and bariatric medicine. She's been a principal investigator in a number of international clinical trials that have focused on evaluating innovative obesity therapies, including the GLP-1 and gut hormone-based treatments. In recognition of the significant contributions to obesity and endocrine care, she's received a number of prestigious accolades, including the 2025 Society for Endocrinology Outstanding Clinical Practitioner Award. And with that, I'd like to pass on the mic to Professor McGowan to talk to us about incretin biology and the oral delivery breakthrough. Over to you, Barbara.
Thank you very much, Khadija. Really lovely to be here. Now I need to share my slide, and I think that somebody else is sharing, so hopefully I should be able to share now. So just give me 1 second, everybody, to get this into presentation mode, and we will get started. Okay, here we go, nearly there. There we are. So it is my real pleasure to be here today, and what I'm going to be concentrating on, and these are my conflicts of interest over the next 20-25 minutes really, is just a reminder, of course, about obesity as a chronic disease, and the disease burden, and of course the limitations of lifestyle intervention. Sometimes we do have to escalate to other therapies. And the focus of the talk today will really be on the oral GLP-1s, why it's been challenging thus far to get oral therapies into our armamentarium for the treatment of obesity, and also, why is it that these new technologies work and new non-GLP-1 peptides work, I will also, non-peptides GLP-1 work. I will also remind you of the data for oral semaglutide from Oasis 4, and then the orforglipron phase 3 data, ATTAIN 1. And then, of course, I will also wrap up by remind you about the data on the injectables, looking specifically at tirzepatide, but also the SURMOUNT-5, which is a head-to-head tirzepatide versus semaglutide data, and hopefully some take-home messages. So, like I said, we do have an epidemic of obesity. We started in 2000 with about 0.4 billion people affected with obesity, 1 in 12. In 2020, this has increased to 1 billion. That's 1 in 7. And by 2035, we're projecting to have like 1 in 4 people living with obesity worldwide. So we do continue to have an epidemic, and we haven't quite turned that sort of the curve, so to speak, which seems to still be increasing. Now, we all know that obesity is associated with around 200 complications, which we broadly divide into 3 categories. So mechanical, such as osteoarthritis, obstructive sleep apnea; the metabolic side of things, including type 2 diabetes, CKD, gout, infertility, PCOS, muscle DMASH, and of course the mental health side as well, anxiety and depression. And of course, we mustn't forget the cancers. There's an increased prevalence of several cancers with obesity. And there are many factors that determine what our weight is. We mustn't blame ourselves. It's not our fault that our weight is what it is. There are genetic and epigenetic factors, and indeed up to 70% of our body weight is determined by genetics, really, and then epigenetics, how those genes are turned on and off according to the environment that we live in. Which of course is generally an unhealthy environment, unfortunately, but that will affect how we respond to the environment. And of course, other factors, psychological factors, our mental health with stress, our lifestyle, how well we sleep, the amount of stress that we are exposed to. So all of these will feed into that equation. And after weight reduction, which can take place with lifestyle or pharmacotherapy, or indeed even bariatric surgery, we then enter that sort of phase of weight reduction maintenance. And I think when the treatment stop, whatever that treatment might be, the weight, we know that often comes back. And there are reasons for that. There are biological reasons to that. And of course, we are built to essentially conserve energy. That's how we survived in the old days when there was no food around. And when we lose weight, with a lifestyle intervention, for example, we see a decrease in the satiety hormones, PYY, GLP-1. There is an increase in the hunger hormones, such as ghrelin. And these hormones, even 1 year after the diet, still haven't gone back to baseline. There is a decrease in energy expenditure, so that we need sort of less energy really to stand still. And of course, all of these, kind of feed into our brain, and we want to kind of regain that weight back. And we have these compensatory biological changes, which means that the weight will usually be regained because that's the normal biological response. Now, we know that different amounts of weight can improve a number of health outcomes, and even small amount of weight loss, such as 0 to 5%, can help with glucose control, hypertension, asthma control, improvement in CKD, for example, or even outcomes in patients with PCOS and infertility. But we know that we need more weight loss if we're trying to get, for example, remission of early type 2 diabetes, for example. We're looking more like 15%. And indeed, we need at least 15% or above to improve all-cause and cardiovascular mortality. So really, we need to try, when we assess patients, we need to try and understand what the complications are, what we're trying to improve, and how much weight loss we require. But really, we're trying to really move away from weight loss towards really what health outcomes we're trying to improve. And really, this is just to remind everybody that despite we have a prevalence of overweight and obesity of about 60%, actually we don't document this very well at all. These are data from mostly Europe and Australia, and you can see the prevalence is nearly above 50-60%. But in the dark red, you can see the actual recorded diagnosis is much lower than that. And of course, if we don't record the diagnosis, we're not going to have the conversation, and we're not going to treat patients. And indeed, if we look at patients receiving obesity management medication, it's actually a very low percentage of those patients who would be eligible. With those with a BMI over 40, only on 5.9% of obesity management medication, for example. So really, we are under treating, and we're not treating really early enough. Now, so where are we with with the obesity management medications in terms of what's approved? So this is just a timeline of really sort of the old and the new, so to speak. And of course, this timeline is not the old drugs were not probably as safe as it should have been. In fact, a lot of them have been withdrawn, and certainly all the amphetamine-based drugs were withdrawn back in the 70s and 80s and the 90s. And even more recently, we've had drugs such as sibutramine withdrawn in 2010, rimonabant removed in 2007 because of side effects, cardiovascular, and for rimonabant because of increased suicidal risk. And indeed, even as recently as 2020, lorcaserin was removed, was taken off market because of the increased risk of cancer. But I'm pleased to say that we now have the incretin therapies, which seem to be well tolerated, and more recently, we now have sort of oral medications which have really added to the injectables that we've seen since really 2014. And so when we're thinking about patients, and when we're thinking about, after the assessment, and we've sort of set personalized targets, this is from the ASO framework, and we start an initial intervention, which might be just lifestyle, for example, but it might be that some patients do need intensification. Then we start thinking about, what is the best, intervention, medical, bariatric, and within the medical sphere, what is the evidence for each medication and the complications associated with the patient. So, and like I said, until very recently, we did not have access to oral peptides. And the reason for that is, due to a number of reasons, really, because peptides are broken down by stomach acid because of the low pH. They are digested by proteolytic enzymes. They are large hydrophilic molecules which can have poor membrane permeability and can easily cross the intestinal epithelium. So there's this very rapid degradation before they even reach the circulation. And then there's also first-pass metabolism, which further reduces drug reaching the bloodstream. So traditionally, we've had very low bioavailability, often less than 1%, and that's why it's been quite a challenge to have oral peptides in this space. So how do newer technologies improve availability? Well, there are absorption enhancers such as SNAC, and I'm going to talk about the oral semaglutide specifically to this, where this technology has been used to improve absorption. And these can raise the pH in the stomach, they protect peptides from degradation and increase gastric membrane permeability. There are other, techniques to improve the formulation. Some are experimental, like nanoparticles, lipid particles. And of course, the other way that we can do this is, instead of using peptides, is to have a non-peptide oral GLP-1 agonist. And we're going to talk about orforglipron, which are small molecules that do not require protection from stomach acid or digestive enzymes. They're more readily absorbed through the GI tract and don't require the absorption enhancer, which leads to often an improved and more predictable oral bioavailability. So why, oral incretin therapies? Now, I'm not going to go through the biology of GLP-1s because it's well familiar to you, and this doesn't change with an oral formulation. The mechanisms are the same. But I guess the advantages are, of course, compared to the injectables, is that can be stored at room temperature. We don't have to have needles. There's no training of, in terms of administration. Potentially lower escalation costs and reduced environmental impact. We don't have to use the pens. There's a greater ease of use, so maybe there's an elimination of social stigma. And there's no injection site reactions, which have been associated with some injectables, GLP-1. So all very good reasons for using this, and this might therefore improve access to obesity treatment. So let's start off first of all with semaglutide, which is called the Wegovy pill. It is a human GLP-1 analog, which is co-formulated with SNAC, which is this absorption enhancer. So you can see the semaglutide molecule, and it's got this absorption enhancer of SNAC, which allows to increase bioavailability. However, there are some factors that will affect its absorption. You need to be fasted when you eat, when you take the pill, and for at least half an hour. Really, you need to have an adequate amount of water, up to about 120 mils. And like I said, the absorption is important, because if we look at semaglutide exposure, it's actually limited. In the fed state, you can see there's very little in terms of the concentration, but the absorption is much better in the fasted state. So this is, I guess, a limitation in a sense that you need to be fasted when you're taking semaglutide. And in terms of weight loss, we're looking, in terms of the results from the Oasis 4 trial. This is obviously randomized patients without diabetes, randomized to either placebo or to the Wegovy pill, which is 25 milligrams of the Wegovy, about 13.6% using the treatment policy estimand, and about 16.6% using the trial product estimand. So I guess similar to injectable 2.4 milligrams in a sense, sort of there or thereabouts in terms of effect of the 25 milligram dose. Of course, it needs to be titrated up slowly every 4 weeks. The results of the trials also showed improvements in terms of waist circumference, systolic blood pressure, and other cardiometabolic parameters that we are familiar with. In terms of how well tolerated, in terms of adverse events, I think it's fair to say that is a significant percentage of nausea, about 46.6% against 18.6% with the placebo. Again, vomiting, about 30% against 5.9% in placebo. The same usual kind of gastrointestinal complications that we're used to seeing, but again, this needs to be titrated up slowly, and hopefully the side effects can then be tolerated and ease off over time. Now, the other molecule, the other oral molecule, of course, is orforglipron, and this is a novel non-peptide, as I described earlier. This is a chemical structure, and really the aim with orforglipron was to develop an oral GLP-1 with a similar efficacy to the injectable, but without the dietary restrictions. And so the way it's been designed, I guess it's a it's a non-peptide, which means it's not subject to the proteolytic degradation in the stomach that I've described. Therefore, there are no food or water restrictions. It has a half-life of 29 to 49 hours, which allows for once-a-day dosing. Of course, it can increase patient adherence, and it works by what's called a biased agonism, where there's activation of GLP-1 receptor biased towards the G protein activation and CMP accumulation rather than beta arrestin recruitment, which is an advantage in terms of the actual the actual mechanism. So a little bit more about, like I said, orforglipron. About 70% of drug reaches systemic circulation, and it's got a high bioavailability, doesn't require an absorption enhancer, and its bioavailability is consistent regardless of the food or water timing, and it can be taken at any time with any liquid or with or without food. So clearly, this is a very helpful, I guess, for patients. Like I said, it's got a half-life of 47 hours, which allows once daily dosing. So there's 1 week of drug exposure after the last dose, which means patients have a meaningful safety window, even if a dose is missed. It has a fast washout of about a week, so it's easy to stop or switch if side effects occur, or in pregnancy if surgery is needed. And GI effects also resolve sooner after dose reduction or stopping. If we look at them from head, the oral semaglutide versus orforglipron, so we can see that with semaglutide, the receptor specificity highly specific to GLP-1 receptor, with the oral off-target effects could be possible with orforglipron. The half-life of semaglutide is 7 days versus a shorter half-life with orfo of 48 hours. They're both stable at room temperature. The manufacturer oral is a complex cell-based synthesis, whereas the orfo is more of a simpler chemical synthesis. And of course, the bioavailability is lower, much lower with oral semaglutide, and much higher with orfo. Administration is daily, and administration requires food and water restrictions with sema, and no food and water restrictions with ortho. Now, looking at some of the results for the ATTAIN-1, which is the orforglipron clinical trial, where patients without type 2 diabetes but living with obesity were randomized to 3 different doses, 6, 12, and 36 milligrams of orforglipron against placebo. You can see here roughly about a 12.4% weight loss, depending on the treatment regimen, on the efficacy estimand, and about 11.2% on the highest dose on the treatment regimen estimand with orforglipron. And this is the mean change in waist circumference. So again, a very, very good, about 11 centimeters, with the highest dose reduction in waist circumference, which is obviously metabolically very important. I'm just showing you the 2 estimands. And interestingly, in terms of body composition, everybody's worried about body composition again, and of course with the oral, it's the same principle. What we can see here is that, if we again looking at the top dose, about 28% reduction in visceral fat mass, 20% of total fat mass, but only 6% reduction in the total lean mass. So really, and actually the body weight reduction due to fat mass loss was 73% against 26% with the lean mass. So sort of at least a sort of 3 to 1 sort of more fat loss than if not more than lean mass loss. So that's also encouraging. In terms of side effects, what we saw here with the nausea, so placebo, I'll find it interesting, they always get some nausea, but about 10%, and about 28, 35, and 33%. So, probably not a massive increase in terms of with the higher doses and with the nausea. Constipation, again, commonly we see this quite commonly, diarrhea around 22%, some vomiting and dyspepsia. So, I would say just, most frequent, the most frequently reported adverse events were gastrointestinal, and I think in line with what we already know about the sort of group of medications. Now, finally, I just wanted to remind you about the sort of injectable data, and which comes from the SURMOUNT clinical trials program, which was a very vast program. Although it started off with SURMOUNT-1, comparing placebo to 3 doses of tirzepatide, which was extended to a 3-year study. And I'm going to quickly show you those again, and then I'm going to remind you about the SURMOUNT-5, which is a head-to-head trial of semaglutide 2.4 versus tirzepatide. So just to remind everybody, with injectables, so the weight loss is of course higher. The injectables are more effective if we're just looking at weight loss. So these are the 3 doses, 5, 10, and 15 from the SURMOUNT-1 trial, showing about 22.5% at 72 weeks. And again, very good results in terms of reduction in waist circumference, which with nearly a 20 centimeter reduction at 72 weeks, clearly, much more than the sort of 11 centimeters that we see with the orforglipron, for example. And the good news is that if you continue to take the medication at, after 3 years at the 5, 10, and 15 milligram dose, that weight is maintained. Okay, so it is a chronic disease. We take the medication, the weight is maintained up to 3 years. So that's all good stuff. And this is just to show you the categorical weight loss, and really just to highlight that 43% of participants taking Mounjaro demonstrated a weight reduction of over 25% on the 15 milligram dose. So that's, very powerful for those patients that do need to lose that sort of weight loss. The SURMOUNT-5 was head-to-head semaglutide versus tirzepatide, and it pretty much replicated the results from the step 1 trial with Wegovy 2.4 and SURMOUNT-1. So we saw about 15.4 weight loss with sema versus 21.6 with Mounjaro on the maximum tolerated doses at 72 weeks. And if we look at the categorical weight loss, we can see that in the purple, that's tirzepatide. Everybody on tirzepatide, I guess, lost more weight at each categorical weight point compared to semaglutide. So, tirzepatide is a more powerful medication in that sense, and 36% of patients taking Mounjaro demonstrated weight reduction of over 25% at 72 weeks. Again, this is the waist circumference data, so 14.7 centimeters with sema against 20 centimeters with tirzepatide. And yeah, so before I sort of wrap up, really, I wanted to just show you the algorithm about which medication we should be using in which patients. And this, of course, is the algorithm that was published at ECO. This is the second version of the algorithm for EASO. Once we've made the choice of using obesity management medication, then if patients do not have complications, that we go down the right-hand side, and this is a total body weight loss. These medications have all been shown to be effective against placebo. If patients have complications, then we sort of divide them into mechanical, either obstructive sleep apnea or knee arthritis, or if they've got metabolic adiposity, pre-diabetes, type 2 diabetes, cardiovascular disease, heart failure, and muscle D, which is divided into MASH resolution and liver fibrosis improvement. This algorithm is based on about 62 clinical trials, all with primary endpoint of weight loss of one of these complications, and it can help clinicians make a decision in terms of deciding which medication might be more appropriate, depending on the most prevalent complication. Of course, patients do present with many complications, so sometimes we have to be pragmatic about which agent to use. So really, to wrap up, I'd like to say that obesity is a chronic progressive relapsing disease requiring long-term management, not just lifestyle intervention. And oral peptide therapies overcome absorption challenges using technology such as SNAC, although there are food restriction challenges. We now have non-peptide oral GLP-1s, which overcome many of these limitations with high bioavailability and no food restrictions. Clinical trials showed that oral semaglutide and orforglipron achieved significant weight loss with safety profiles having consistent with the GLP-1 class. And I think the future of obesity treatment is moving towards highly effective, convenient oral therapies with the potential to improve access, adherence, and long-term outcomes. And with that, I'd like to thank everybody. I'm very happy to take questions. Thank you.
Thank you very much, Professor McGowan. That was an excellent overview of the oral anti-obesity medications from how the breakthroughs has happened. We will take questions at the end of the two talks. So what I'm going to do now is talk about the future of obesity medications. So if the organizers can allow me to share my screen. Okay. Right, so let's share that. And let's get that on presentation mode. Right, so what I'd like to do now is follow up on that fantastic talk by Professor McGowan and look into the crystal ball and see what the future holds for obesity management. Before I do that, these are my disclosures. And the outline is very simple. I'm going to just look at the clinical evolution of obesity medications, the current landscape, and what is in the future pipeline. So there has been indeed a paradigm shift in the way we manage obesity treatment. We recognize that because it's a chronic disease, we are going to have chronic treatments. And we know from both clinical practice and clinical trials that when we discontinue the obesity medications, there is a recurrence of the weight that was lost usually within a year, and they might sometimes be a reversal of some of the cardiometabolic improvements that were accrued during weight loss. That is, of course, as a result of the neurohormonal adaptations that occur with weight reduction. So what's the clinical evolution of what is the current sort of landscape? Well, as Professor McGowan had already shown us, there was the first generation anti-obesity medications, and we have the more powerful sort of second generation ones because they were able to give us the more than 15% reduction in body weight. So if we look at the legacy agents, orlistat, which is hardly ever used now in clinical practice, but they are the oral agents such as the phentermine topiramate, which act primarily through the sympathomimetic and GABA receptors, which can give up to an 8.6% reduction in body weight. And then there's naltrexone bupropion, which is an opioid antagonist, which also acts on the dopamine, which can also be delivered as oral, but twice a day, with about a 5% reduction in body weight. Then, of course, the newer generations, of course, the incretin therapies that we've already sort of heard about, were able to sort of move the dial from the 5 to 15%. So one would ask then, is there still a place for the first generation anti-obesity medications? And perhaps we could still use those in certain situations whereby we have lack of access or to overcome some of the supply barriers that we might have with the newer therapies. And we can also tailor them for a dual purpose treatment. So it might be helpful to use, say, phentermine topiramate or bupropion and naltrexone in patients who have binge eating disorders, sleep apnea, or to help them with smoking cessation. So there is still a place for these agents as well. And of course, as has already been mentioned, the historical sort of therapeutic chasm happened when, with the introduction of these powerful incretin therapies, which are now able to give us the kind of weight loss that is nearly close to what happens with metabolic surgery. So obesity pharmacotherapy is also beginning to address some of the complications of obesity, because it's not just about looking at the number on the scale. So we are interested in trying to reduce the cardiovascular and metabolic complications, to try and reverse prediabetes, to diabetes remission as well, to address the liver pathology, and of course all the cardiovascular complications as well. The mechanical complications are just as important: obstructive sleep apnea and osteoarthritis. And then also looking at physical function and reduction in food noise. So the quality of life actually improves with the use of obesity medications. So the emerging obesity pipeline is really happening really at quite a steady pace. And now we're looking at these multi-receptor agonists. So there are a number of those in clinical trial, and some of which have been able to report even their phase 3 clinical trials. So we have combinations of amylin with the GLP-1 receptor agonists. There's, of course, the GIP receptors with the GLP-1. We've seen the utility of tirzepatide. And then we will soon be hearing about the combination of GLP-1 receptor agonists with the glucagon receptors, particularly in the field of metabolic-associated liver disease. I'll touch upon retatrutide, which is a triple G combination where you have glucagon, GIP, and GLP-1. And then the future is even more brighter in that we're going to be also having GIP receptor antagonists with the GLP receptor agonists and things like maritide. And then to tackle this issue of muscle loss and try to preserve the muscle, we have agents that are going to be combined with the GLP-1 receptor agonists that try to reduce the muscle breakdown. And in the future, we'll also be hearing about GLP-2 receptors combined with the GLP-1 receptor agonists. So this is what the emerging therapeutic pipeline looks like. We've already looked at the oral formulations, the convenience of taking them as pills, eliminating those injection barriers. And then we're going to be looking at dual and triple agonists. The synergistic hormone targeting pushes the weight loss beyond the 15 to and past the 25%. And of course, looking at the solutions for muscle preservation to have these monoclonal antibodies that can actually preserve the muscle while we're shedding the fat. So it's a race between the oral race and the duration race. The oral race you've already had quite extensively about oral semaglutide and oral orforglipron and the differences between the two. And then there's the duration race, trying to push the boundaries even further for a potential of monthly dosing. I'm not going to talk too much about orforglipron because you've already heard quite a lot about it, but there are a number of glucagon targeting agents as well already in development, mazdutide, survodutide, and retatrutide. And all these agents are geared towards trying to reduce liver fat content. So we will be hearing in the future more about these agents, particularly for our patients with obesity who also have metabolic associated liver disease. So a little bit more about retatrutide, the molecular properties. It is a novel synthetic molecule which combines the three Gs, so GIP receptor, glucagon receptor, and the GLP-1. It has a very potent agonist activity at the GIP receptor and a balanced activity between the glucagon and the GLP-1 receptor. So it has a ninefold greater potency at the GIP receptor than the native GIP ligand. And because of this change in the amino acid sequencing, it has a mean half-life of about 6 days. What are the potential mechanisms? There are quite a number of them. There is a potential for improvement in the lipid profile, of course, in regulation of appetite, energy expenditure, improvements in glycemic control, and even a possibility of reducing inflammation. So the program that has been involved with retatrutide is the TRIUMPH program. It's a phase 3 development program looking at a number of clinical situations. So people with obesity, with obstructive sleep apnea, with knee osteoarthritis, and also looking at the cardiovascular effects in these individuals. In the interest of time, I'm not going to be able to talk about the different trials, but there has been data presented just last month at the ADA with TRIUMPH-1 showing really encouraging data around retatrutide. So what about maritide? And the paradox here is where agonism meets antagonism. We know that tirzepatide stimulates the GIP, whereas maritide blocks it. Paradoxically, blocking the GIP receptor also produces a reduction in the appetite, but there's a profoundly more extended duration of action, thereby allowing for monthly administration. There's some phase 2 studies which are encouraging, again showing that there's a dose-dependent response in adults with both obesity with and without type 2 diabetes, and we're seeing with the highest dose a reduction, a change in body weight in the order of 19%. And then, of course, there's this question always, as we know, with medications that might, and you know, even with metabolic surgery, that we might be losing some lean mass, and therefore it would be, you know, beneficial if we were to have a preservation of the lean mass. And to do that, there are these monoclonal antibodies that block the myosin. A number of agents are still, again, in the phase 2 sort of trials. This is bimagrumab combined with semaglutide, again showing a dose response sort of effect, whereby with the highest dose of bimagrumab, with the highest dose of semaglutide, giving us a reduction in the total lean body mass of around 20%. So the sort of clinical reality of obesity management now is really about pushing the barrier to get a more sort of transformative reduction in body weight. So we're not, the expectations for us and our patients is we're no longer satisfied with just 5%, although the 5% also does help with some sort of metabolic parameters. But if we can get more than 20%, then that would mean that we're able to reverse some of the obesity-related complications and improve cardiovascular outcomes. It is a chronic disease that would require uninterrupted pharmacological support. And of course, the future is trying to look at the composition of these medications as well to try and make sure that we're able to preserve the lean mass as well. So obesity is, as we all know, a heterogeneous condition. And perhaps in the future, what we will be doing is matching the treatment with the individual phenotype. So for those individuals with a high BMI, but with a high risk of sarcopenia, say our elderly patients, a combination of GLP-1 with an activin or myostatin inhibitor might be more beneficial for them. For those individuals with obesity and metabolic associated liver disease would benefit from having a GLP-1 combined with the glucagon agonists. And then for individuals with severe obesity on monotherapy, not getting to their targets would benefit from the triple G agonist. And for those of our patients that have phobia to needles, we do have the oral options available now. But the future perspectives, I think there are quite a number of things that we still need to consider. First of all, is to evaluate in future clinical trials the effectiveness of a combined sort of interventions. Hopefully, the more we have, we will also be able to reduce the inequities in access to obesity care. Guidelines, of course, will need to be continually refined. We do need to integrate weight management with cardiovascular care. And we are hoping, as you've seen from the obesity treatment algorithm that from the EASO framework, is that we should try and aim to have personalized weight management treatment. And of course, I think even now and in the future, we're going to be leveraging a lot on digital health technologies, the wearable devices and so on. A lot of gaps still remain. The magnitude of weight loss, glycemic control, cardiovascular outcomes, muscle loss, liver comorbidities as well. So the future, I would say, is quite bright. We're moving from mono agonist to multi agonist, pushing that boundary to 20% weight loss and beyond. We're moving from quantity to quality, so the introduction of muscle-preserving agents and metabolic accelerators, and then from a more broad to a more specific sort of targets. It's not a one-size-fits-all. We're going to have to use a nuanced approach in order to address every individual's needs. So to summarize then, I would say it is an exciting time in obesity medicine. We have multiple treatment options currently available and in development. And with that, we probably will be able to move on to a more personalized medicine despite this crowded therapeutic landscape. With that, I will end my presentation and stop sharing so that I can introduce our next speaker. And before I do that, I would again like to remind you that we are going to take questions at the end of the third talk. So please put your questions in the Q&A tab. The next talk is an industry symposium. It is, as I mentioned earlier, sponsored by Lilly, and it's going to be delivered by a good friend and colleague, Dr. Jalal Nafash, who is a consultant endocrinologist at Dubai Diabetes Health Center. He's also a clinical assistant professor of endocrinology at MBRU. He is an active clinical researcher and investigator in a number of international studies that focus on diabetes, obesity, and novel metabolic therapies. So over to you, Dr. Jalal.
Thank you, thank you, thank you. I'll try to pick up the slides. Can you see it?
Not yet. Okay, there we go.
All right. So, so this is me. So I work in Dubai Diabetes Center, which is mainly everyone is diabetic, but today we're going to focus on mainly in earlier stage. So how can you even avoid becoming diabetic to start with? And again, we always start with disclaimer when we do presentation for Lilly. So this is the first one. So I've been asked to talk on behalf of Eli Lilly regarding using Fondayo and Monjaro. No photos or screenshots, preferably. So we're going to jump directly to it. So what's the indication? Now, of course, as you know, Monjaro from a perspective of weight loss is being indicated as a drug to reduce calorie intake in patients with mainly BMI over equal 30 with 27 BMI with complication. And in a way is similar for Fondayo. And that's because all the trials usually looking at treatment of obesity is usually they use this criteria when they enroll in the patient. And so the label will be reflecting how the trial design. I think in the long term, over time, things may change where we may end up by treating patients at a lower BMI if they do carry complication related to their excess weight. Now, what we try to talk or discuss is try to look at two different patient profile and try to see the evidence we have from clinical trial and see what's the difference between the product and kind of make a decision which patient may be preferably better on one product than other. Now, and this has been alluded to much, but the whole thing we always have to remember is the chronicity. I mean, obesity is a chronic disease. And so when a patient come and you try to go, discuss medical treatment and we discuss the idea that the treatment for weight loss agent is a chronic treatment. A lot of patient, does not accept this fact and they want to take the product for 6 months or 9 months or even 3 months and to lose a few kilograms or whatever their target is, and then they stop and you try to explain to them that this is not the nature of the disease. And I think it's just this mental status where patient may have a problem using a treatment, GLP-1 or GLP-1 GIP, as a treatment for diabetes, but they're not willing to take it chronically to lose weight and not become diabetic to start with. And I think that's really where sometimes it doesn't make sense, when you look at it. It is a progressive disease. It tends to get worse over time. It become harder. And of course, as we get older anyway, metabolic rate goes down. And there are stages in our life where suddenly you see switch, for example, in postmenopause in women. It is a relapsing disease. So a lot of patients will lose and regain the weight. And that's really one of the worst outcome. So you want to explain to the patient that not only you want them to lose weight, you want them to maintain it. Because a lot of patients, what they do, they lose the weight. Of course, they may lose lean mass with it. And then typically they gain pure fat. And so over time, what you're going to see is patient maintain maybe similar weight, but at a lower metabolic rate and more fat mass. And it is multifactorial. So there's many factors that influence the weight. Of course, genetic is a big part of it, but there's environment, there's psychological and all that. Now, we know that weight loss is important. And, the more weight you lose, you can cause more benefit. And, for example, to prevent type 2 diabetes, 5 to 10% will reduce quite a bit your incidence. But to reverse type 2 diabetes, typically you need about 15%. Now, one thing, again, with those slides, you have to remember that the benefit on the cardiovascular disease here and the mortality that alluded here is related to the weight loss only. But as you know, with the management or with the medication with the GLP-1 and GIP, actually we have cardiovascular data that seems not 100% weight related, i.e. that even if you don't achieve a significant weight loss, you continue to get cardiovascular benefit. So here what we're talking about is the benefit from the weight loss per se, and not only the class itself. So if we have two patients, and we'll start with the first patient on the left, which is a Miriam, 40 years old, BMI 30, just mainly had a BMI of 30, which is officially called as obesity, with hypertension. She had tried that and exercise. And she's looking to something simple. She's busy, full-time, have kids. And then on the right side, you have Sarah, 30-year-old, BMI 34, with dyslipidemia, borderline blood pressure, not diabetic yet, had tried attempts at weight loss and conscious of her diet. She walked daily, and there's a significant family history of obesity. So we'll start with Mariam, which is again the typical patient we see that they come to you after they arrive to a point that they feel they're not achieving any outcome. You try healthy lifestyle and you may succeed for a little bit of time and then you snap back and it becomes frustrating because it's the chronicity. It's not a one-time job and it's done. And so when you look at this patient, you can see like 2 years ago, she had a BMI of 28, and then she gradually continued to gain weight till she arrived to you today with a BMI of 30. And, the question is, when should I intervene? Should I intervene 2 years ago? Maybe it's better. Should I intervene now, or should I wait another 5 years when the patient is even worse? And, I think at the end of the day, it's always better to be aggressive earlier because you're more likely to achieve your target with a lower baseline than, of course, with a higher baseline, whichever agent you use. And so why we may consider using Fondayo for this patient? Well, multiple parts. One of them, it's once daily. We're going to go over that. Can be taken anytime, and there's no restriction from perspective of food or water. Now, again, it's a non-peptide, and that's been already alluded to, so I'll skip those quickly. And there's no restriction from perspective of food or water, so they don't need an enhancer to improve absorption, the bioavailability in the 70% plus. It does not break down the gut, so that's not going to be an issue in that perspective. Now, again, as a GLP-1, as we know, it stimulates insulin secretion, suppresses glucagon, but it has an effect also on the brain and the appetite center to reduce hunger and improve satiety in that sense. And the patient would not feel, in a way, like eating. And, we have to kind of differentiate this then not eating because you're sick to your stomach, because this is not only mechanism of the stomach that slow down the gut, it's actually there's an effect direct on the brain. So patient will lose weight. Sometimes they feel like they don't care about the food as much. And that's a little bit different than when you get sick to your stomach and you're not eating, because that's not the mechanism. And actually, if you look at the data of those medication and you look at the data on all GLP-1s, what you're going to see that those who have a GI side effect and those who don't have a GI side effect mainly tend to lose the same amount of weight. So it's not the GI discomfort that make you eat less and lose weight. It's actually there's direct effect on the brain. Now, what happens if I use orforglipron or Fondayo? So the major study is called ATTAIN-1. And again, a patient were randomized to 3 doses, so they titrate the dose. So one arm was 5.5 milligram, 9 milligram, 17.2 milligram compared to placebo. What you see at 72 weeks, that at the 5.5, there was 7.8% reduction or 8 kilogram. 9 milligram, they have 9%, and the 17 milligram, they have 12.4%. And similarly, it showed clearly that there is statistical significant reduction in the weight in the population, again, who fit the criteria, who are BMI of 30 or 27 and above with complications such as prediabetes or dyslipidemia or so. So that's kind of the average reduction. Now, one thing when a patient comes to you, you have to explain to him that this is the average reduction, but there is a heterogeneity in the response. So some patients over responder, some people respond less. So typically you need to see how they do in about 3 months and decide if you need to change the treatment or do a different intervention in that sense. Now, one thing we really need to focus on is most patients, what they look at is the weight, the fat, the waist, how they look at. But one thing we really need to be clear to explain to them that not only they lost that 12.4%, the blood pressure went down. And those patients, if they were taking antihypertensive medication, we need to explain to them to monitor their blood pressure because they may need to reduce or stop their BP meds. There's improvement in high sensitive CRP, again, indicating a benefit on the cardiovascular. There's reduction in the LDL. There's significant reduction in triglyceride. And you have to remember, a lot of treatment we use for triglyceride reduce the triglyceride by 30%. You're going to have some patient you may reduce or stop the treatment altogether. So there is a benefit across the board and not only the weight. And so we have to look at the diabetes as a whole component and not just how much overweight I am. Now, when you look at the side effect, and here we look at the patients who experience 5% or, I mean, the population who had 5% or more. Again, as we know, with all GLP-1s, nausea and GI symptoms are the most common. So nausea, you can see here, is somewhat very similar across all the three arms. Constipation, maybe touch a bit more on the higher dose, diarrhea, vomit, and dyspepsia. Can you expect who's going to get one? And the answer is no. But we need to explain to patient that initially you're going to get, or you have third chance mainly to get GI side effect. It tend to be mild to moderate, transient in nature, and it gets better over time. And we have to explain to the patient the things they need to do to reduce the chance, of course, including not eating big heavy meal, not eat a fatty meal, spicy meal. So there are things that can be done to reduce or totally stop the chance of getting side effects. Now, how to start? You can start with 0.8 milligram, and then you increase it to 2.5 milligram. And then you go on to individualize patient based on the patient response to either go to 5.5, 9, or even increase to 14.5 or 17.2. And again, at each step at 30 days. So mainly here, you're talking about 6 different steps. Now, again, does everybody need to be on 17.2? The answer is no. It really depends on the patient. You have to see how they lose weight, how they tolerate it, and the speed of the response. Sometimes I may not directly increase the dose if I see the patient responding very nicely. Not everybody will need 17.2 milligram. You may have patients who take only 5.5 milligram and they lose 12%. So it's really very variable, and you have to see how the patient responds. Now, how to take it again? Once a day, anytime, with or without food. Very simple. Don't chew the pill, of course. You have to swallow it. And one thing that's important, that you keep it in the original packaging so it's protected from the light. And if you skip it more than 7 days, you may need to reinitiate at lower dose and escalate the dose back. So try as much not to miss it, that long, so you don't have to deal with this issue of going back to lower dose, because then you will need to request a different prescription. Now, at the end, we need to remind the patient that we're looking at it as a weight loss agent, but also we're looking at the benefit from a dyslipidemia improvement, triglyceride lowering effect, blood pressure lowering, and improvement in the parameter, and not only as fat losing drug, if you want to call it this way. We have to educate the patient on what to avoid from a food perspective, or reduce any chance of side effect. So when we come back to the patient saying, well, why would I maybe want to use, Foundayo for this patient? Well, number one is she's in the first time she was in treatment. So, some patient may not want to start injection right away. They want to try something simpler and say, okay, I'll try a pill, see how that works. And at any point, if patient did not tolerate, or if patient did not achieve the benefit or the weight loss effect you want, you always have a choice to use, mainly if you want to call it stronger drug, which is the Mounjaro. That's a choice. There's no restrictions, so you don't have to worry about the timing part. And if a patient is a frequent traveler, for example, this may be a nice option, so they don't have to deal with, taking an injection once a week, and they come late to take it. Sometimes they come on time, because some individual are a frequent traveler, and that may make it a little bit hard to do. And we have to explain to them that not only we're helping them with weight loss, is we're going to help this patient with her hypertension, dyslipidemia. So we're preventing any progression. And of course, we're preventing her from becoming diabetic to start with. Now, if we look at the different profile, which is Sarah in this case. So this is a patient who has a higher BMI, who has been dealing with the weight for more time and multiple attempts. The first patient just let it slide. She didn't work hard on it. It was her first time to try any medical treatment. And so this patient, if you want to call her a pro, she's tried different things. Nothing seems to be working for her. And she come to see you. Her blood pressure is 134/84, LDL is 130, no type 2 diabetes yet, family history of obesity, and again, BMI of 34, waist 92, and A1C 5.7. Again, she's pre-diabetic. At some point, maybe in the next 5 to 10 years, she become diabetic. She already most likely have a degree of beta cell failure to start with. And so patient will come to you, they're very frustrated. They'll say, you know, I tried many things, I regained the weight, I'm tired of this, I want to do something. And so we have to sit with the patient and we explain to them that we have multiple choices. You explain to her based on her BMI, based on her history, and of course her higher BMI, that, you know, you may want to prefer to use a little bit more effective drug, if you want to call it. Now, what's the difference between this and GLP-1? So again, we know how GLP-1 works. GIP is a little bit different. And so the GIP will have an effect to regulate glucose uptake and modulate lipid uptake. And in the old days, GIP was thought to be the lipid storing hormone. But actually, when you have the activation of both GIP and GLP-1, you have a significant fat loss. And not only that, when you have GIP with GLP-1, you reduce the GI effect, especially the nausea that's caused by the GLP-1. So when you look at native GIP only activation is different than when you look at combination of hormone, and that's really pretty fascinating. So the combination not only reduce food intake, reduce appetite. Typically, patient will tell you, I really don't care about food, especially when they take Mounjaro. And a lot of patients, I mean, I have quite a few patients that this was the first time in their life. They were so excited that this is the first time they can see food and they don't jump on it. This is a feeling they never experienced. The craving for food is reduced. Craving for sweet is quite a bit reduced. And, you know, again, that's quite exciting for a lot of patients who suffer. I mean, every day you go out and you see people eating this and we're just dying to eat more. And now you have something that can help you with it. Now, how much weight loss I get with it. So when you look at the Surmount-1 study, which was 2,500 patients, patients were randomized to either placebo, a Mounjaro titrated to 5 milligram, and 10 milligram and 50 milligram. And what you can see that in the placebo group, starting with a weight of 105 kilogram, that the weight loss was merely 2.4% at 72 weeks. Now, at the 5 milligram, you got 16%. At the 10 milligram, you get 21%. At the 50 milligram, you get 22.5. So when you discuss with the patient, you can discuss with them the data on SURMOUNT-1, and you explain to them what kind of average response at 72 weeks. And, you know, some patient will say, well, I want to lose like 8 kilograms a month. And you say, well, this is not really a healthy way to do it. I do not want you to lose this fast. So what you want to achieve your target, whatever your target is, but we have to do it preferably slowly over time till we arrive to kind of a steady state, if you want to call it, which tend to happen around a year or a little bit more. Now, does everybody who take 10 milligram will lose 21.4%? The answer is no. You're going to have some patient who lost 30%, 35% with 10 milligram. And you're going to have some patient who lose only 10%. If there's an explanation, there's really not a good, clear explanation of the heterogeneity of the response yet. Now, when you try to look at mainly a 3-year data, so 176 weeks, and this is an extension of SURMOUNT-1, but this is only the population with prediabetes at randomization. So you remember the initial trials, 2,500 patients, this is 1,000 patients. And what you can see here that the patient who maintained the treatment, mainly 176 weeks, they maintained the weight loss. So those who maintained the 5 milligram, they maintained the weight loss of the 5 milligram. Those who took 10 milligram, they maintained the weight loss of the 10 milligram. And those who took the 15 milligram, they maintain it. So as long as you're taking the medication, you are able to maintain mainly all the weight loss achieved with it. So that's the first question. Do I have chronic data on ability to maintain the weight? And the answer is yes. Now here you have 176 weeks when patients showed very clearly if they continue to take medication, they're maintaining the weight loss. Now, the second question is, how do I compare that to high-dose semaglutide? So this is a study where a patient, again, it's an open label because two different devices, and patient will randomize semaglutide either 1.7 or 2.4, so the maximum tolerated dose, MTD, or again, tirzepatide, Mounjaro, again, 10 or 15. And what you see here very clearly in this open label study, that the semaglutide achieved 15.4% versus 21.6. Again, the Mounjaro was statistically significant superior in the weight loss. Now we come back to the same issue. What kind of other benefit I get? You get a reduction of 10 millimeter mercury. Now, this is a little bit even more than you get a lot of blood pressure medication. So a lot of patients, when they take Mounjaro, you really need to explain to them what they adjust their BP meds, because a lot of patients will need to reduce their BP meds. I have patients who totally stop. There's improvement in their lipid. There's 34% reduction typically, or sorry, 25 to 30% reduction in triglyceride. This is somewhat similar when you treat patients even with agent to lower the triglyceride. So when a patient comes to you, you have to explain to them that, some patient may complain about the cost of the treatment. And one thing we have to explain to them that not only you lost the fat, I actually reduce your cost on the BP meds. I reduce the cost on the diabetes medication, the other diabetes medication. The patient is diabetic. I reduce the cost on triglyceride medication. And of course, they save money on the food because typically they're going to eat less food. So there is a significant benefit across board. And, that I think this is, at least for me, what I see very commonly, that patients fight on keeping the drug because of the cost. And you have to explain to them that, you're actually saving on all the aspects beside their health, of course, that you're able to reduce the cost of all the other medication. Now, what's about heart failure? Now, the Summit heart failure is a very intriguing study. So what they did in this study, they looked at patients who are 40 years old or older with HFpEF, mainly preserved ejection fraction, with ejection fraction 50% or more, and patient, again, with BMI of 30 or above, with or without diabetes. And they were randomized either to placebo or Mounjaro. And patient received maximum tolerated dose, so that could be 5 or 10 or 15. And they continued the treatment. Now, what you see here that's very intriguing, that there was a 38% reduction in the cardiovascular death or worsening in the heart failure event. So mainly, there was a reduction in the hospitalization from the heart failure. They need to get any intravenous diuretics or treatment for the heart failure, or need to be admitted for any urgent care center, or any intensification of the oral diuretic treatment. So there was a significant reduction, now, of course, in a big part from reduction of the heart failure, but that's also an additional benefit. You have to remember a lot of patients with obesity, metabolic syndrome, and diabetes, they tend to have diastolic dysfunction. And that's in a way showing you very clearly that there is an additional benefit. So not only there's a reduction in the weight of 22, 23%, not only there's a reduction in the A1C, of course, we didn't talk about that. Not only there's a reduction in triglyceride, not only reduction in the waist, typically average waist loss, it's not presented here, is 20 centimeter. So, I mean, you're talking about somebody go from size of 40-inch to, 32 or so. So that's all a benefit. And on top of this, you have the benefit if a patient have a history of HFpEF in a sense. The last question will be, what should I do after treatment? Now, I wish the study was done a little bit differently, but what they did in the study, they treated patient mainly at the maximum tolerated dose of Mounjaro, which is 10 and 15 in this trial. And then patient were randomized to 3 arms. So the first arm will say, if you're taking 10, I'll keep you on 10. Or if you're taking 15, I'll keep you on 15. And that's the dark blue line. And what you see here, that the patient maintained the 22.4% weight loss. Now, the other arm, they switched to Mounjaro 5 milligrams. So if they're taking 10 or 15, they went to 5 milligrams. And what happened in this group, they regained some weight. So they gained about 5 kilograms, but they maintained the majority of the weight loss. Now, the group who went to placebo had the worst outcome. They went up quite a bit. So they had only 10% weight loss versus they were 22. So what that shows that if you treat for 60 weeks and you stop, it's not a very good idea, because a lot of time, again, it takes long time for the body possibly readapt for the new weight. So for your body still does not accept the current weight. And of course, your hunger hormone are up, your satiety is down, and once you stop the treatment, you go back to the old habit. So what you need to make sure that patient understand the data, that stopping the drug cold turkey is not a good idea. And we have multiple studies on this agent and even on semaglutide that shows very clearly it would not make sense. So before you start the patient on treatment, you have to explain to them chronicity of the obesity, the fact it's a relapsing chronic disease, and the fact that treatment is chronic as we treat diabetes and high blood pressure. And I think that may click with them more. Now, this is just to show you that when a patient went to or kept their treatment on, which is mean the 10 and 15, they maintain 100% of the weight loss. If they reduced to 5 milligram, they maintained 70% of the weight loss. And here, when they went to placebo, they mainly only 44%. But you have to remember, this is again only 2 weeks, 112. If you actually keep it longer, I can tell you most likely those who are on placebo not only will go back to the same baseline weight, they may go over it. And not only that, they'll be usually pure fat gain. One thing that's very important in any patient you start on weight loss trial or treatment, sorry, that you need to emphasize on the importance of good nutrition, adequate amount of protein intake, and the importance of resistance training. If you do not do exercise, you are more likely to have a lean muscle loss. Again, it seems to be less on Mounjaro, but irrespectively, whichever way you lose weight, you have to do an exercise. And if you do resistance training, you're most likely not going to have any muscle loss. So you need to focus on the exercise from the beginning of the treatment, throughout the treatment, and even as a maintenance. And that will be important part. So how do we start? Well, again, as you know, it comes in a pre-filled dose that have enough for 4 injection. So you start with 2.5 milligram for 4 weeks, then you jump to 5 milligram, and then you individualize at need. And if you need any further um, increase, you go to 7.5 for 4 weeks, then 10 for 4 weeks, 12.5 for 4 weeks, and 15. Do you need to go to everybody to 15 milligram? The answer is no. Now, again, there is the company recommended maintenance dose, which is that 5, 10, and 15. But at the end of the day, I think it's all related to you as a physician and the patient to see how they respond and see how they tolerate and what dose they feel good in it, what dose they tolerate more, what dose they maintain their hunger at a certain level. It's okay to feel hungry, but you don't want them to have those extreme surges that they used to have before. So coming back to the patient, why did we choose it? Because this patient has dealt with weight loss and gain, and she has not been successful. She is comfortable with injection. We have the data and Surmount because, again, we need her to lose a lot of weight. I need this patient to lose 20%. So yes, you can use Fondayo on this patient, and yes, she may lose 20% of Fondayo, but again, you have to look at the average weight loss reduction. And so you say, I'm looking to have about 20%, so maybe I prefer to start you directly on Mounjaro. And again, the patient had significant increase in triglyceride, which also will help with this. And we discussed with the patient again that we have data to support that not only I can reduce her weight, I can maintain it. I have at least 176 weeks data, and I'm going to be able to achieve that, which is something she never was able to achieve. Every time she lose, she regain within a year. So at the end, you look at it. So if you look at the treatment history, if patient treatment naive, they want oral pill, you may want to consider Fondayo, especially if prefer oral. If they have a higher BMI, you're looking to achieve 20%, 18% weight loss, maybe start Mounjaro. If patient want to go only to 5 milligram, even Mounjaro, you have 16% weight loss as an average on their study. If a patient want to maintain the weight, of course, you can use either Fondayo or Mounjaro for that reason. If a patient is frequent traveler, they don't want to carry with them injections and go and put it in the fridge, then you may want to use Fondayo. So I think the whole idea, what we're trying to say here, is every patient is different, and you have to look at it this way. Not everybody should take Mounjaro, and not everybody should take Fondayo. And I think, I hope kind of showed you 2 examples on 2 patients, Mariam and Sarah. Both of them have obesity. Both of them have a little bit of profile. One of them, the profile may fit better with Fondayo, but it doesn't mean it's wrong to start her on Mounjaro, but I'm just saying we have data to support both treatments. Both of them will have significant weight loss reduction. And again, the GI side effect is mild, but But again, you can teach the patient how to reduce the chance of the side effect. And I think I'll stop at this point and give back to you.
Thank you so much, Dr. Jalal, for that very clear, very comprehensive and informative talk. You've highlighted the patient profiles and which patient to choose which drug. And it's, I guess, time for the Q&A session. Thank you to the audience for your questions. There are quite a number of questions that have come through, and we'll try and take some of them in a thematic way. So, because the questions, as I see, are pivoting around practical sort of clinical points on initiating treatment, some around efficacy, potential side effects, and how to make that therapeutic distinction. So I think the first question is asking about when we're switching from, if somebody's on injectable therapy and they want to switch on to the oral, do we need to start with the lowest oral dose, or what would be the dose? So if somebody was on 15 milligrams of Mounjaro and you wanted to switch them then to oral to Fundeo, what dose would you start them on?
So there's the attain trial. Now, in this trial, they went back to square one. So mainly they started from the 0.8. And what they're seeing in the group who went to it, actually, they had about 5 kilogram weight regain. I typically do not do that. Again, this is off, if you want to call it, label.
And
And
you were a
so,
maverick.
no, I mean, it doesn't make sense to go. I mean, somebody taking Mounjaro 15 and you go back to start to 0.8 of Fonda, it's just like illogical for me.
Right.
So if there is like a chart to equate them, no. What I try to do, I go middle. So I mean, I may go 5.5 if they were taking Mounjaro 10-15, but I mean, this is me trying. Again, did I do that? Not yet, because I didn't have anybody switch since I have the Fondayo. And you have the choice to keep the patient on injection. I mean, what I do, I reduce the injection. So I go, 10-15, and then I try to reduce. Now, I showed you the data here, the 60 weeks, and then they went to lower dose. But I watch patients. I mean, if I see that with the lower dose, they start to inch up, I may increase the dose again. Every patient is different. But for me to try to reduce the dose, they have to be committed on the exercise part. So I need to make sure they're exercising. Typically, you aim for about 240 minutes a week, doing resistance training, having enough protein, then yes, I back off the drug. But it would not make sense that a patient doing nothing and I try to back off the medication, because their chance of maintaining it is almost 20%.
Right. Any other thoughts, Professor McGowan?
Yeah, so I don't actually know the answer to that question. I mean, they are, I think pragmatically, you may not want to go to the lowest dose, but I don't actually know what the official advice is. I can tell you that switching from injectable semaglutide 2.4 to oral 25, and the advice is to go straight from 2.4 to 25 milligrams of oral sema. But in terms of the pharmacokinetics, but I don't know specifically, to this particular question. So I think I would probably at first use some caution and probably start off with the lower doses. And I think as we become more comfortable, perhaps if we see that they're better tolerated, then we might be able to start at a high dose and obviously titrate up. Because I guess they're slightly different molecules in a sense that obviously tirzepatide is a GLP-1, GIP. Foundayo is technically a GLP-1 agonist. But yeah, so we'll see. Experience will tell us.
Okay, watch the space. In women on oral contraceptives, how should we advise them if they're going to be taking orforglipron?
I'm not aware of any drug-drug interaction in that sense, so I would not expect that anything need to be adjusted.
Okay.
I would not take it in the same time anyway, but I mean, that's to the extent of it.
Are there any precautions or any sort of interactions that do they need to be on a higher dose, a lower dose, or is there something that we need to caution them against?
Against You mean
Or
taking
if
the drug?
somebody is, yeah. So if somebody is on oral contraceptive and they are planning to take Foundayo as well, is there any sort of specific instructions that we need to give them?
No, I mean, I'm not aware of anything need to be adjusted, but irrespective, I asked them to take that separate time, but that to the extent of it. I treat them as anybody else.
Okay. And for individuals who are planning to go for surgery, who've already started on Foundayo, when would we be advising them to stop the treatment?
When you do the injectable, typically we tell them a week. Now with the Foundayo, maybe I will ask them to stop it 2-3 days before, but not longer.
Shorter half-life. Okay, so that was the questions that came through on the practicalities of initiating treatment. There were a few concerns about complications, and some people did ask in your practice whether you've come across patients with NION, the non-atretic ischemic changes in patients on GLP-1 therapies. And the question was how common it is. I know it's quite a rare complication. I've not had any, but there've been a number of reports. So I don't know what your take is on that.
I mean, yeah, go on.
Sorry.
It's fine. It's
Okay.
fine. I mean, it's incredibly rare. I think we all know, like, roughly about, I don't know, 2 to 10 cases per 100,000 people or something like that. And I think patients with, I think mostly with semaglutide, with type 2 diabetes, probably showed us sort of possibly a doubling of what is an exceptionally very, very rare event. So I think it's very difficult to say. And certainly, I don't we have any data on orforglipron with regards to this particularly. There's just not enough data because we haven't used it enough. So I think I wouldn't be concerned at this point in time, indeed, for any of them, to be honest, for any incretins, because I don't think we've shown causality.
Absolutely. Yeah. And also, again, for Professor McGowan, there's a question from Dr. Suha, who is asking whether we can use the second generation, treatments in cases of depression or psychiatric disorders.
Yeah, so the simple answer is yes. So I think there have been lots of post hoc analysis, and we've actually published on this as well, where there's absolutely no evidence of any increased anxiety or depression or any mental health disease. If anything, the evidence seems to suggest there's usually an improvement, and certainly these agents are generally effective also in patients who take antidepressants, because we know obviously antidepressants tend to increase weight, but we know that in general, the incretin therapies are also effective. I think there was a very recent report that was published suggesting otherwise. I think it was possibly systematic meta-analysis, but like I said, I honestly, I think it's we should be absolutely treating patients with mental health issue, anxiety and depression with this medication. I don't think there's any signal that it gets worse, and if anything, there seems to be an improvement.
Yeah, there was initially some concerns about suicidal ideation, but of course that as well doesn't hold any
no
weight.
evidence.
So
Absolutely no evidence for
that at all. A question that's open to both of you as well is around microdosing, and patients do have financial constraints at times, and they resort to all methods to try and maximize the use of the medication. So they wanted to know about what your thoughts would be on this issue.
I'll let her start.
Well,
so you're talking about using it for a longer time and that. I mean, this is totally off-label. So clarification number one, not approved by the company, not studied. So the durability or stability of the product is nobody knows. So can you use a higher dose pen to take a lower dose? You can. Do we do it on some patients? Yes, I do. But I'm very clear about this, that it's, we don't know because it was studied for that long of time. And so, I mean, that to the extent, but again, it's off-label. It's one of those things that we do sometimes because And even if you do microdosing, patient will fight you, say, well, it cost me like, let's say, whatever. And I say, God's sake, you eating less by 800 dirham. You know what I'm saying? I mean, it's like, look at the other things. People just look at the price of the drug. I was like, you're eating less. You go out one time a week. Actually, if you calculate, if you order from outside delivery, again, Professor Barbara, everybody here order delivery. So if you have 2 times a week less delivery, that's it. That's really the price of the drug. So I don't know. I mean, for some reason, when it comes to this, people don't want to pay money, but they're willing to pay for other things.
Okay. All right. Okay. So this one is to Professor McGowan. Wonderful lecture, ma'am. In the current era of obesity epidemic, do you still feel that BMI has a role in treatment and diagnosis of obesity, especially when the latest guidelines emphasize the role of waist circumference reflecting visceral adiposity? I feel that many patients with obesity are missed just simply based on the BMI. Your thoughts, please.
Thank you for that question. So there's no question that BMI is not enough to diagnose obesity. That's also why EASO has a new definition of obesity, which goes beyond BMI and really looks at a BMI of 25 and above, and a waist circumference of, waist to height ratio, forgive me, of more than 0.5 plus one complication as a definition of obesity. And of course, that BMI of 25 can be lower in certain ethnic groups. So really introducing the waist to height ratio as a much more powerful measure of visceral adiposity and cardiovascular risk. So BMI is okay at population level, but it doesn't really tell us very much about where the fat is, what the cardiometabolic risk is. So on its own, it's not good enough. And so we absolutely have to start using other measures, and depending on where you are and how easy it is, like I said, waist to height is fairly straightforward to do. And then you're absolutely right that it would capture up to another nearly 20% of people that would have been missed and gone untreated without a definition of obesity, where there is obesity there and an increased cardiovascular risk. So we do need to pick these patients up earlier, and we need to treat them earlier to prevent, obviously, the complications later on. So I completely agree that it's not enough.
Okay, yeah, absolutely. And Tia is asking whether there's an ideal weight or healthy weight loss per month for patients on the anti-obesity medications or any weight loss program. So do we have targets? Do we, say you need to lose a certain amount per month?
I mean, I don't know what you guys try. I try not to achieve more than maybe 3% a month in the first 2-3 months, and then maybe 2% a month after that. To be practically, I don't necessarily follow the weight loss trials, like Monjaro, 2.55, 7.5. I mean, if I have somebody doing very well with 5, I may keep them on it. I don't push the dose higher, because what am I trying to achieve? I don't want them to lose muscle. I want them to have enough nutrition. I don't want them to be so calorie deficient. So that's what I do. I mean, again, there's no study doing what I do per se, but I mean, I try to make more sense. I don't want them to be mainly like somebody who's starvation camp, they don't eat at all. I have people who hardly eat 500 calories. They come and they're very happy about that. And it's like, what the hell? So, I mean, you need to see that they're eating less, but not too less, Yeah.
Okay. And, taking it from there, then the eating less, there is a question about, do you then start with your vitamin supplementation right away when you start the medication? Somebody was
Tell
asking.
them take multivitamin. I mean, you can treat them as you're treating bariatric patient. And this is medical bariatric in a way.
Okay, all right. There is another question, slightly different, around selecting therapies based on phenotype. How do you choose between tirzepatide, semaglutide, orforglipron, semaglutide oral? What are sort of your criteria for selecting one or the other? So,
yeah, I mean, I'm not sure there's such a thing as a phenotype. I can't sort of say, oh, you're going to respond to that, you're not going to respond to that, you should have that or that. So certainly the we should individualize treatment. I think, in general, as a very general sort of intervention, the orals, I think, probably sit better with those lower BMIs between 27 and 35 as an earlier intervention. It doesn't mean that you don't use injectables, but I think, it could be a primary care drug, where you're starting off much earlier. And the orpha versus the oral sema, I guess to some extent depends on, if you're taking, I don't know, other drugs where you have to fast in the morning, you might not want to have that hassle, so you go with the orforglipron. And I'm sure cost will also play a part, in a sense, depending on the cost of each drug. With injectables, like I said, they're both very good. The elderly, I might again, the oral might be good for the elderly where you're wanting sort of slightly slower weight loss, for example. I mean, right now, I've been using perhaps Wegovy with the elderly to try and, because I got tirzepatide is such a powerful drug in a sense, so, and I may not want as fast a weight loss, but clearly if I have patients with significant, high BMIs, 40 or above, especially with the number of complications, I might tend to choose tirzepatide. And then, of course, we have the algorithm, which is obviously a very evidence-based. And then, what is the most prominent complication? What is going to maybe affect life expectancy, or even the quality of life of a patient. If a patient has got sleep apnea, they don't tolerate the CPAP at night, they really want to get rid of their OSA, then I'm thinking, well, we know the evidence lies with tirzepatide, for example. That's what the clinical trial data is, so would go with that. If they have a number of complications, that heart failure, I don't know, liver disease, muscle D, again, looking at an agent that can cover all those diseases, so the algorithm can help me. But it is an individualized choice, and I don't think there's one right answer for each patient, but I think, like I said, broadly, I think the orals have now filled the gap in the sense that we can probably start treating people a little bit earlier in that pathway.
I think the fact that we have lots of choices is actually a good thing, because if somebody doesn't respond to one, they can always get the other.
Exactly.
And
sure.
And so the more choices we have, the better it is for patients, and we're not actually limited to using one agent. And so, yeah, it is going to be very sort of personalized. This question comes up almost in every webinar, again and again, but I want to sort of hear your thoughts so that we can try and put it to rest, and relationship of GLP-1 receptor agonists with cancer.
Oh,
Yes, I know you were going to respond like that.
So, I mean, it's overblown. So I have quite a few people, if they have low thyroid, they don't take it because they heard somewhere they cannot. So there's really no evidence. Actually, there was a publication showing that even GLP-1 users seems to have significant reduction in the cancer. It's the other way around. So as you know, a lot of cancer is related to obesity. And so it seems that actually you may reduce cancer. Again,
Very
this
simple.
is
Yeah, it's very simple.
So it's not,
there's no controversy here.
Yeah.
It's if you lower your weight, you reduce your overall risk of any type of cancer, full stop. And the GLP-1s are very much.
I think the medullary cancer is very overblown. I mean, it's 1 in 40,000. Since I moved to Dubai, I have 0 medullary cancer. In the US, I had 2. So, I mean, it's very rare. If there's a family history, don't give it. Even the pancreatitis part is very, I mean, do I have people with history of pancreatitis? I have people who had pancreatitis, but, they had a gallstone and, so that I may I may put them on GLP-1. Again, I documented that we talked to them that, they had pancreatitis, but they're remote 20 years old, and there's no recurrent, and there's no risk factors, and they're not alcoholic, and they don't have high triglyceride, and there was a reason why they got it. It's not idiopathic. And then I put them back.
Absolutely. Yeah. I think a lot of times people forget that obesity in and of itself is a risk factor for cancer, and therefore, they try and pin it on the medications and forget that the condition itself is a risk factor. There's lots of other questions around, doing tests, any specific tests before you want to, start these treatments. And of course, we do not encourage or request any specific tests with if you
I mean, you want their A1C, you want maybe they're diabetic.
so that other than what is required in
Well, I
the
mean, you
guidelines,
can
yeah?
do ALT, AST, CBC, and measure their FIB4 calculated. I mean, you can see if they have any symptoms of sleep apnea. So you see if they have any comorbid obesity complication.
So
You
what
know?
you were looking for is just the complications of
Right,
the
right.
obesity rather
Yeah.
than looking for any sort of specific.
No. I would not do a neck ultrasound. It's been because here in Dubai, a lot of ultrasounds done.
Yeah, no,
Unnecessary.
definitely not. It's obviously good to have a baseline, just not so much for the drug, but actually for the assessment of obesity itself.
Yeah.
Is there any, possibility of liver disease, muscle D? So, having an AST, ALT, platelets to
Yeah.
work up a FIB4 score is useful. To have obviously lipids, to have a renal function,
Yeah.
to have HbA1c, all the things that we're aware. Nutritionally, again, it would be helpful to know that you're not iron deficient to start off with, or vitamin B12, folate, vitamin D deficient. There's certainly no need to do, zinc, copper, and all the other nutrients. But if somebody loses a significant amount of weight, and I'm talking about 35, 40%, and they might not be taking any multivitamins, there may be a role. But I always find that other markers, if they're low in folate, vitamin B12, iron, it's likely they're going to be low in other nutrients as well, just pragmatically, because of the lower nutritional intake. I mean, it's not, although, we're not chopping any bits of the stomach, it's not an absorption issue, it's just an intake issue, but there's no need. I think it's useful once a year to have regular bloods if we can. I think that's it's a good thing to do, to just check somebody's health.
Yes.
But it's not.
I think that the major issue also is we face people getting amylase lipase checked. It's really not
again,
a
no
good
need.
idea.
No need.
Even in the Monjaro data, I think 5-6% of patients even have 3 times normal.
Yes,
The level.
it's normal to have that. So obviously, if you've got symptoms and you're worried about, obviously gallstones and pancreatitis, that's a different story. But I mean, there's absolutely no role of measuring these markers regularly on these medications.
I mean, if somebody had the gallstone problem to start with, maybe do the surgery before start.
Well, no, exactly. I mean, if they're clearly symptomatic with the gallstones, then you would have a cholecystectomy, get over that, and then restart the medication. That's
all right. Great. I think we're kind of running out of time. We've taken all the questions. I apologize for the ones that we've not been able to answer. But I'll summarize by saying that we have looked at the management of obesity. It needs to be holistic. The pharmacotherapies have greatly helped our patients in not just losing weight, but in maintaining the weight loss as well. And it's not just about weight loss, but about the other clinical outcomes as well, and improving on their quality of life. So with that, I would like to first thank our panelists for your great insights. I would like to have special thanks to Lily for providing us with, the support and the platform to having these discussions. I would also like to thank our audience for taking their time, and we're very pleased that we've had a very good attendance tonight. I would like to thank the EDS technical team, because the streaming has been seamless. We haven't had any glitches, so thank you very much, the people in the background. The CME will be available 4 weeks after the webinar, and as I mentioned earlier, you can watch the webinar on demand on the EDS website. So with that, I'd like to thank everybody. Have a great night.
You too. Good night.
Thank you very much. Thank you.
Thank you.
Bye-bye. Bye.